Hello everyone, welcome to this medicine lecture series in rheumatology, and in this video we will be talking about sarcoidosis. It's a pretty interesting condition and is particularly important as far as NEET-PG and INI-CET are considered. If you take a look at the PYQs, you might find a few questions from this topic, and the question is usually straightforward. So if you have read this topic even once, you would be able to answer the question if you can find certain important keywords. Starting off with the etiopathogenesis of sarcoidosis. So it is mostly a sporadic condition, right? Typically seen in otherwise healthy young adults, but it can also be familial. Non-caseating granuloma is the pathological hallmark of sarcoidosis. So it's a very important point, right? It's a very important keyword as such for sarcoidosis. You can compare it with caseating granulomas, which are more suggestive of infective conditions like tuberculosis, right? So in sarcoidosis, non-caseating granulomas are seen. Coming on to the etiology, the cause is currently unknown, but the most likely hypothesis is that it is due to some infectious or non-infectious environmental agent which acts as a trigger, which triggers an inflammatory response in a genetically susceptible host. So the overall pathogenesis is due to an interplay between the environmental agent and the genetic susceptibility of the host. Right. Now, there are two important triggers mentioned here which might be framed as some keywords in a question. So, much higher incidence of Propionibacterium acnes in the lymph nodes of sarcoidosis patients compared to control. So, Propionibacterium acnes in the lymph nodes of patients is an important keyword here. Then, presence of mycobacterial protein, the MTB associated catalase peroxidase protein, right? MCAT-G protein. So this is important in the granulomas of some sarcoidosis patients, which is very resistant to degradation and may represent the persistent antigen in sarcoidosis. So Propionibacterium acnes and MCAT-G protein can be, important keywords as far as sarcoidosis pathogenesis is concerned. Immunopathogenesis, the disease is mostly mediated via cellular immunity and that too via Th1 cells. So CD4 positive Th1 cells are the main culprit here, right? Then then we have the HLA association. So HLA-DRB1 is the associated HLA haplotype, and again there are two HLA-DRB1 haplotypes which are one of which is 1101, which is associated with an increased risk for developing sarcoidosis, while HLA-DRB1 03 haplotype is associated with good prognosis and early resolution. So trick to remember this can be more the numbers, higher the risk, right? For sarcoidosis, while lesser or smaller the number, it is associated with good prognosis and faster resolution. So moving on to the clinical manifestations. So this table right here shows the frequency of common organ involvement in sarcoidosis. The percentages here are not important, you don't need to remember them, it's just to give you an idea. As you can see, lung are almost always involved in sarcoidosis patients, followed by skin. So lung and skin are the two most commonly involved organs in sarcoidosis, right? And then we may also have eye involvement, extrathoracic lymph node, liver, spleen involvement, and even neurologic and cardiac manifestations can be seen in a small minority of patients. Starting off with lung, respiratory complaints like cough and dyspnea are the most common symptoms, and cough and dyspnea are in fact the most common presenting symptoms of sarcoidosis overall. Right. So now sarcoidosis is classically considered as a restrictive lung disease. It also makes sense since there will be multiple non-caseating granulomas infiltrating the lung parenchyma. So it will present with a restrictive lung disease picture on pulmonary function testing. Right. Although some patients may also present with obstructive disease pattern on pulmonary function tests where they will show reduced FEV1 to FVC ratio. Pulmonary artery hypertension may also be seen in a very small minority of patients. So the classic picture is restrictive lung disease. This you must remember. Now, chest X-ray and CT imaging may also be used to characterize lung involvement, and we have a very important scoring system here known as the SCADing scoring system. So this table right here is very important. You must remember this table. So as you can see, stage 0 corresponds to normal patient, while stage 4 corresponds to pulmonary fibrosis. Stage 1, 2 and 3 are where students get confused. So stage 1 corresponds to bilateral hilar lymphadenopathy with normal lung parenchyma, while stage 2 has both hilar adenopathy as well as pulmonary parenchymal infiltration. So stage 2, 2 means both lymph node are involved plus lung parenchyma is also involved, right? So both the things are involved simultaneously. In stage 3, parenchymal infiltration is there, but there is no hilar lymphadenopathy, right? So only parenchymal involvement. While in stage 1, only lymph node are involved, parenchyma is normal. And stage 4 is pulmonary fibrosis. So that's how you can remember this table scatting scoring system. Moving on to the skin involvement, the classic finding is erythema nodosum due to panniculitis, and then we may also have maculopapular lesions, hyper and hypopigmentation, keloid formation, and subcutaneous nodules. Another classic manifestation of sarcoidosis is lupus pernio, right? It is diagnostic for chronic sarcoidosis, right? So lupus pernio is basically erythematous to violaceous indurated plaque involving the bridge of the nose, the area beneath the eyes, and the cheeks. Now this same distribution also is might be seen in one another condition known as the malar rash, which is a characteristic of an autoimmune disease known as SLE. So this right here, this image right here shows the malar rash, while this image shows the lupus pernio, right? So you might get confused. So you must know how to differentiate between lupus pernio and malar rash. So as you can see, lupus pernio is more of a violaceous rash, while malar rash is erythematous, right? Lupus pernio will have a more indurated raised lesion, indurated plaque, while malar rash is typically a flat lesion. Also, malar rash has a characteristic nasolabial sparing, as you can see, which may or may not be present in lupus pernio. So that's how you can differentiate between lupus pernio of sarcoidosis and malar rash of SLE. Then we also have eye involvement, where the most common manifestation is anterior uveitis. It may also lead to chronic granulomatous panuveitis, dry eyes, etc. In liver, we have intrahepatic cholestasis, right, which is associated with ALP elevation on LFT, and this may also complicate further, leading to portal hypertension. Then in hematologic involvement and spleen, bone marrow, uh, and extrathoracic lymph node involvement can also be seen. Most common hematologic problem is lymphopenia due to sequestration of lymphocytes into the areas of inflammation. So lymphopenia is the most common hematologic abnormality, followed by anemia. Leukopenia per se is uncommon, or you can say less common. Splenectomy may be indicated for massive symptomatic splenomegaly or profound pancytopenia. If there is very high inflammation leading to sequestration of cells, then then a splenectomy may be indicated for such patients. Extrathoracic lymphadenopathy can also be seen in some patients of sarcoidosis. Moving on to the nervous system involvement, the MRI will show granulomatous inflammation, as it's basically causing non-caseating granulomas. Sarcoidosis can involve CNS as well as PNS, but certain areas are more commonly affected in neurosarcoidosis, which are the cranial nerves. So, cranial nerve involvement, particularly the cranial nerve 7, lower motor neuron palsy, which is transient in nature, and it can also be mistaken for Bell's palsy, because Bell's palsy is the characteristic idiopathic lower motor neuron palsy of facial nerve. So you have to read the question well, and if there are some keywords suggesting sarcoidosis picture, then you might have to think about neurosarcoidosis, right? Other areas affected in neurosarcoidosis are basilar meningitis, myelopathy, anterior hypothalamic disease. Then we might also have seizures and cognitive changes. So these all can be the manifestations of neurosarcoidosis, right? So remember the comparison with Bell's palsy here. Another differential diagnosis for neurosarcoidosis can be multiple sclerosis, right? Why? Because in some patients with sarcoidosis, multiple enhancing white matter abnormalities may be detected on MRI. Right now, similar pattern on MRI of this white matter abnormalities is also seen on multiple sclerosis. Right, it also leads to white matter abnormalities, white matter plaques. So here again, you might have to differentiate between neurosarcoidosis and multiple sclerosis based on the keywords given in the question. Right, so Bell's palsy and multiple sclerosis can be some tricky differentials for neurosarcoidosis. Moving on to cardiac involvement, we may have granulomas in myocardium as well as in the conducting system, and depending on the location, the manifestations can be congestive heart failure, arrhythmias, or even heart block in case granulomas affect the conducting system of the heart. In case of musculoskeletal system involvement, the patient may have myalgia, arthralgia, fatigue, sarcoidosis affecting the renal, affecting the kidneys. There might be granulomas in kidney, which may lead to nephritis, but this is relatively much less common. The more common cause of renal involvement in sarcoidosis patients is hypercalcemia. In fact, hypercalcemia is the most common cause of sarcoidosis associated renal disease. The granuloma itself does not cause renal disease as much as hypercalcemia does, right? So that's a very important point here. Salivary and lacrimal gland involvement can also be seen, and that will be associated with the drying of secretions, etc. So this completes the clinical manifestations of sarcoidosis. All right, so now let's talk about the syndromic variants of sarcoidosis. This is our third topic here. There are two syndromic variants of sarcoidosis, the Lofgren syndrome and the Hereford-Waldenstrom syndrome, also known as uveitis fever. So both of these have good prognosis, as you can see. Lofgren syndrome is an acute form of sarcoidosis with good prognosis associated with HLA-DRB1 star 03 haplotype. So as we studied before, 03 haplotype is associated with good prognosis and faster resolution. Thus, Lofgren syndrome also has disease resolution within 2 years. And it is characterized by a triad of arthritis, erythema nodosum, and bilateral hilar lymphadenopathy. So, as the name itself can work as a mnemonic, where L stands for lymphadenopathy and EN in the Lofgren stands for erythema nodosum, right? Along with arthritis, which you will have to remember. Hereford syndrome again is also known as uveitis fever, and again in the name itself you can figure out that it will have uveitis fever will have uveitis, or specifically anterior uveitis, parotitis and fever, along with facial nerve palsy, right? So these are the two syndromic variants of sarcoidosis. So moving on to the investigations. So first we have the serum investigations. Due to excess vitamin D synthesis by macrophages in the granuloma, uh, sarcoidosis is typically associated with increased calcium levels, hypercalcemia as well as hypercalciuria. In fact, hypercalciuria is the more common finding, right? And we have also studied that increased calcium is the reason why kidney involvement is seen in sarcoidosis, right? That is the in fact the most common cause of sarcoidosis associated renal disease. Then elevated serum ACE levels may also be seen, although it has low sensitivity specificity. So this sort of, these things sort of work as keywords. So the examiner might frame a question with a non-caseating granulomatous disease of lungs, skin, where the patient has increased calcium and increased serum ACE level. So these sort of keywords should help you come at a diagnosis of sarcoidosis, right? Then complete blood count will show lymphopenia. It might even show anemia. Leukopenia is relatively less common. So this we have already studied in clinical manifestations. Bronchoalveolar lavage will show lymphocytosis and increased CD4 to CD8 ratio. Right. In fact, a ratio of CD4 to CD8 ratio higher than 3.5 in BAL is strongly suggestive of sarcoidosis. So bronchoalveolar lavage itself might help come at a diagnosis of sarcoidosis. In chest X-ray, we already studied the scadding scoring system. Another important sign here is the Garland triad, also known as the 1-2-3 sign or the pawnbroker's sign. It is basically a lymph node enlargement pattern seen on chest X-rays. So what happens here is that three groups of lymph node are seen. So the first one is the right paratracheal lymph node. This is the right hilar lymph nodes, and then the left hilar lymph nodes. So this forms the Garland triad. On chest HRCT, this is the chest HRCT, right? And this is showing the galaxy sign, right? So as you can see, this whole dark galaxy with a lot of these white stars. So what are these stars? These are basically multiple small non-caseating granulomas which are coalescing with larger granulomas, right? So this is known as galaxy sign. Then we also have nuclear medicine scans like gallium 67 scintigraphy. These are used to identify areas of granulomatous disease. PET CT and MRI may also be used for this purpose. The two characteristic signs here are the panda sign and the lambda sign, right? So the panda sign is seen due to bilateral involvement of parotid and lacrimal glands in sarcoidosis. So as you can see in this image, bilateral parotid gland involvement is there, as well as bilateral lacrimal gland involvement is there. So if you superimpose this image, this resembles the face of this animal, hence this sign is known as panda sign, right? Then we have the lambda sign. Lambda sign is similar to Garland triad. Basically, it is seen basically bilateral hilar lymph node. So the right hilar lymph node and the left hilar lymph node, and then we have the right paratracheal lymph node, right? So similar to the Garland triad in CXR on gallium scintigraphy, this forms the lambda sign because the shape of these, if you join these, it will form a lambda-like shape like this, right? Hence the lambda sign. Then we have biopsy for patients with compatible skin lesion. A skin biopsy should be considered. Of course, a skin biopsy is the easiest to take compared to other biopsies. If there are no compatible skin lesions for taking a biopsy, then we might have to take a liver biopsy or a extrathoracic lymph node biopsy or even a muscle biopsy. On histopath examination, as we have already talked, we will see non-caseating granulomas, that is the pathological hallmark, with Schaumann and asteroid bodies. So these are some important names you'll have to remember. Alright, so finally moving on to the treatment part. This is not really important from an examination point of view. This is just to give you a broad idea. So for asymptomatic patients, we usually take a conservative approach and we monitor the patient for any disease progression. For a localized disease with limited cutaneous and or limited ocular lesions, topical steroids alone might suffice. While for a multi-system disease with multiple organ systems involved simultaneously, we will have to give systemic steroids alongside steroids sparing immunomodulators like hydroxychloroquine, methotrexate, calcineurin inhibitors, azathioprine, and even biologicals like monoclonal antibodies, etc. So this completes our discussion on sarcoidosis. Thanks for watching and see you in the next one.